Section 2 is on Principles of Orthopedic Oncology. Broad classification of primary tumors of the bone is based on its origin. They are: number 1, hematopoietic bone tumors; number 2, chondrogenic; 3, osteogenic; 4, unknown origin; 5, fibrogenic; 6, notochordal; 7, vascular; 8, lipogenic; and 9, neurogenic. Some of the examples of benign tumors under the same classification are as follows. Chondrogenic benign tumors are osteochondroma, chondroma, chondroblastoma, and chondromyxoid fibroma. Osteogenic origin bone tumors are osteoid osteoma and osteoblastoma. Benign tumors of unknown origin are giant cell tumor and fibrous histiocytoma. Fibrogenic benign tumors are fibroma, desmo-plastic fibroma. Vascular tumor is hemangioma. Lipogenic tumor is intraosseous lipoma, and neurogenic tumor is intraosseous neurilemoma. Malignant tumors under the same categories are: number 1, hematopoietic tumors are myelomas or lymphomas. Number 2, chondrogenic origin malignancies are primary chondrosarcoma, secondary chondrosarcoma, dedifferentiated chondrosarcoma, mesenchymal and clear cell chondrosarcomas. Number 3, osteogenic origin malignant bone tumors are classic central osteosarcoma, perosteal osteosarcoma, periosteal osteosarcoma. Number 4, malignant bone tumors of unknown origin are Ewing's tumor, malignant giant cell tumor, and adamantinoma. Number 5, fibrogenic malignant bone tumors are fibrosarcoma or MFH. Number 6, notochordal malignant bone tumor is chordoma. Number 7, vascular malignant bone tumors are hemangioendothelioma or hemangiopericytoma. Musculoskeletal tumor society staging systems of tumor, also called Ewing system grading. Grade 1 are low grade, grade 2 are high grade, and grade 3 are metastatic. Each grades are subdivided into A and B, A intracompartmental and B extracompartmental tumors. So we have staging system 1A, 1B, 2A, 2B, and 3A, 3B. Behavior of the tumors have been classified into 5 categories. Number 1, benign latent, which never becomes malignant. Example is non-ossifying fibroma. Number 2, benign active. Example is aneurysmal bone cyst. Number 3, benign aggressive, which are locally aggressive but do not metastasize. Example is giant cell tumor. Number 4, malignant low grade. Example is perosteal osteosarcoma. And number 5, malignant high grade. Example is classic osteosarcoma. Preoperative staging evaluation of bone tumor involves clinical examination, X-ray examination, bone scan, CT scan, magnetic resonance imaging, and angiography, particularly if limb-saving surgery is planned. Ewing has put forward the way to analyze the X-ray appearance of the bone tumor. Number 1, location of the lesion. Number 2, extent of the lesion. Number 3, what is the lesion doing to the bone. Number 4, what is the bone doing to the lesion. And 5, is there any hints as to its tissue type. Biopsy consideration is only after staging studies are obtained. Improper biopsy site has got a very high chances of interfering with the treatment and has got major setback in limb-saving procedures. Surgical procedures can be: number 1, intralesional, where the dissection goes through the pseudocapsule. Number 2, marginal, where the entire lesion is removed but the pseudocapsule is left behind. Number 3, wide or intracompartmental, is an en-bloc resection. And number 4, radical resection is an extracompartmental resection. The same principles of surgical clearance apply to amputation as well. Malignant bone tumors. Malignant bone tumors are of three types. Number 1, mesenchymal cell tumors are sarcomas. Number 2, bone marrow cell tumors are myeloma and lymphomas. And number 3, metastasis. Osteosarcoma and Ewing sarcoma are the most common mesenchymal bone tumors occurring during childhood and adolescence. Above the age of 40, metastatic bone tumors are the most commonest tumors. Multiple myeloma and metastatic carcinoma typically increase in frequency with increasing age. Let's talk about osteosarcoma. Osteosarcoma is a high-grade malignant spindle cell tumor arising within a bone, and the characteristic feature is production of tumor osteoid. Macroscopic classification of osteosarcoma is: number 1, central osteosarcoma, which is classic osteosarcoma and is subclassified on the microscopic ground as osteoblastic, chondroblastic, telangiectatic, and low-grade osteosarcoma. Number 2, surface osteosarcomas, which are again subclassified as perosteal, which is a low-grade tumor, periosteal, and high-grade surface osteosarcomas. Number 3, osteosarcoma of the jaw. Number 4, multicentric osteosarcoma. Number 5, secondary osteosarcomas due to Paget's, post-radiation, or dedifferentiated chondrosarcoma. Number 6, osteosarcoma derived from benign precursors. Microscopy: spindle cell sarcoma producing osteoid is osteosarcoma. Most common sites of occurrence of osteosarcoma are around the knee joint, 50%, and proximal humerus, 25%. Radiological characteristics have been described by Wilner as 2% sclerotic, 22% osteolytic, and 46% mixed osteosarcomas. Chemotherapeutic protocol has been combination of drugs: MAC, methotrexate, which is high-dose methotrexate, Adriamycin, and Cisplatin. Limb-sparing resection in malignant tumors consists of 3 phases: resection of the tumor, skeletal reconstruction, and soft tissue muscle transfers. Contraindications to limb-sparing surgery are: number 1, major neurovascular involvement; number 2, pathological fractures; number 3, inappropriate biopsy site; number 4, infection; number 5, immature skeletal age; number 6, extensive muscle involvement. Easy way to remember this is 6 eyes. First eye is involvement of the vessels and nerves. Second eye is involvement of muscles extensively. Number 3 or third eye is injury. Fourth eye is inappropriate biopsy site. Fifth eye is infection. Sixth eye is immature skeletal age. Osteosarcoma is low-grade tumor, typically involves the posterior aspect of the femoral condyles. Periosteal osteosarcoma is high-grade lesion in contrast to perosteal osteosarcoma. Chondrosarcoma. Chondrosarcoma is a cartilaginous tumor without evidence of direct osteoid formation. 5 types of chondrosarcomas are described. Number 1, central; number 2, peripheral; number 3, mesenchymal; number 4, dedifferentiated; and number 5, clear cell chondrosarcomas. Half of all chondrosarcomas arise above the age of 40 years. Most common sites are pelvis, femur, and shoulder girdle. Chondrosarcomas are low-grade tumors, except rare types like mesenchymal and dedifferentiated chondrosarcomas, which are high-grade tumors. Microscopically, single or multinucleated giant cartilage cells are characteristic. Radiographic findings can be: lytic lesion with faint calcification is the most commonest finding. Diffuse lesion without any sclerotic border is suggestive of highly malignant lesion, and endosteal scalloping is the key sign of malignancy in chondrosarcoma. Treatment of chondrosarcoma is surgical removal. Giant cell tumor of the bone. Locally aggressive tumor, 75% of them occur around the knee joint. 2 to 8% chances that giant cell tumor may undergo malignant transformation. Important to remember that the GCT appears after skeletal maturity, and the counterpart of giant cell tumor before fascial closure is osteoclastoma. Microscopically, giant cells are seen in abundance. Block is 90% curative. Curettage with or without bone graft has 40 to 75% recurrence rate. Marco popularized curettage and cryosurgery using liquid nitrogen -20 to -40 centigrade of temperature. Other measures available are radiation therapy or PMMA reconstruction of the defect. Fibrosarcoma of the bone. Histological pattern is herringbone pattern of interlacing bundles of collagen fibers. Fibrosarcoma occurs in middle age and can either be central or cortical. Microscopy of malignant fibrous histiocytosis suggests or shows cogwheel pattern of collagen fibers. Ewing's sarcoma. Ewing's sarcoma is the second most common bone sarcoma of childhood. Characteristically, 50 to 60% of the Ewing's tumor occur in flat and axial bones. Long bones, mainly diaphyseal segment, is involved. Microscopy shows poorly differentiated small round cells with marked homogeneity. Radiographically, Ewing's tumor is commonly a highly destructive radiolucent osteolytic lesion. Sunburst or onion peel appearance seen in Ewing's is because of periosteal elevation and periosteal reaction. Musculoskeletal staging system does not apply to round cell sarcomas of the bone because of the predilection for lymphatic system of Ewing's and round cell tumors. Treatment. Ewing's are generally radiosensitive. Surgical resection is increasingly becoming popular. Multi-drug chemotherapy is also used. Radiation dose is 4,500 to 6,000 C-Gyri in total. 1,000 to 1,500 C-Gyri is preferably applied to the tumor site and rest to the affected bone. Multiple myeloma. Most commonly affects spine and ribs. Commonly seen between 50 to 80 years of age. Radiological appearance of punched out lesion is characteristic. Renal failure is a common complication. Criteria to diagnose solitary plasmacytoma are: 1. Solitary lesion, 2. Histological diagnosis of plasmacytoma, and 3. Marrow plasmacytosis should be less than 10%. Microscopically, plasma cells are seen. Well-differentiated plasma cells will have eccentric nucleus, peripheral chromatin, and have a clock face appearance. Treatment. Multiple myeloma is treated by multi-agent chemotherapy. Solitary plasmacytoma will need radiotherapy, and treatment of complications like fractures or hematological problems may need surgical intervention. Metastatic bone tumors. Metastasis is the most common bone tumor in patients over 40. Bone scan is highly accurate in detecting distant lesions. Most common site of involvement are spine, pelvis, femur, and ribs. Metastasis can be osteolytic or osteoblastic. Osteolytic are the more common. Osteoblastic metastasis can occur in breast, prostate, lung, and bladder tumors. Treatment in metastatic bone diseases is highly individualized and aimed at: number 1, pain relief; number 2, prevention of fracture; number 3, continued ambulation; and number 4, to avoid cord compression. Benign bone tumors. Osteoid osteomas are less than 1 cm in diameter, and if the bone forming tumor is more than 1.5 cm in diameter, it's called osteoblastoma. Chondroblastomas typically arise in the epiphysis of a skeletally immature child. Unicameral bone cyst. Its benign bone lesion, commonly affecting proximal humerus, involves metaphysis as well as diaphysis of the long bones. It's radiolucent, expansile with well-defined margins. Cold on bone scan. Lesion is central in nature as against eccentric lesion of fibrous dysplasia or aneurysmal bone cyst. Aspiration will yield yellow fluid in unicameral bone cyst as against blood in aneurysmal bone cyst. Treatment options: aspiration, flushing and injection with methyl prednisolone acetate, or intralesional injection of autogenous marrow. Section 3 is about bone and joint infections, broadly classified as: number 1, acute hematogenous osteomyelitis; number 2, subacute osteomyelitis. Brody's abscess is classified under this heading by some authors. Number 3, subacute epiphyseal osteomyelitis. Number 4, chronic osteomyelitis. Number 5, chronic-sclerosing osteomyelitis. And number 6, osteomyelitis of miscellaneous group caused by rare organisms like Salmonella, Brucella, tuberculosis, etc. Few words on blood supply of the epiphysis and metaphysis. In an infant, some metaphyseal vessels may penetrate the open growth plate and ramify in the epiphysis. In a child, nutrient artery terminates as an end artery adjacent to the growth plate. In an adult, metaphysis and epiphyseal vessels communicate freely. Chronic bony infectious process forms sequestra, which is the dead bone. Involucrum is the new bone laid down by the periosteum and surrounds the sequestra. Cloacae are the openings in the outer involucrum through which the sequestra makes its way out. Laboratory and X-ray investigations as well as isotope bone scan are helpful. Acute hematogenous osteomyelitis. Most common pathogens are as follows. Number 1, infants less than 1 year, group B streptococcus, staphylococcus and E. coli. Number 2, children 1 to 16 years, Staph aureus, Streptococcus pyogenes and Haemophilus influenza. Number 3, adults, commonest organisms is Staph aureus. Subacute osteomyelitis, Brody's abscess, most common organism is Staph aureus. Subacute epiphyseal osteomyelitis, the only causative organism is Staph aureus and typically affects the talus in children. Chronic osteomyelitis, most common causative organism is Staph aureus. Staging of chronic osteomyelitis is done by Kearney. Type 1 is endosteal osteomyelitis. Type 2 is superficial osteomyelitis. Type 3 is the medulla as well as cortex is involved. Type 4 is diffuse extensive involvement of the bone. Septic arthritis. Joint infection can occur at any age. Most common organisms causing septic arthritis are: number 1, children under 2 years, H. influenza and Staph aureus. Between 2 to 16 years, Staph aureus and Streptococcus pyogenes. Between 16 to 30 years, N. gonorrhoeae and Staph aureus. Number 4, more than 30 years, causative organisms are Staph aureus and Streptococci.